The moderators for this session of live cases are Dr. Rajiv Gulati, Dr. Kintur Sangvi, Dr. Manik Chopra, Dr. Hasid Joshi, Dr. Ajay Swami, Dr. Gajendra Dubey, and Dr. Jay Shah.
Case number 5,
the case.
65-year-old male, hypertensive, presented with the NSTEMI, having moderate LV dysfunction with ejection fraction of 35%. PCI to LED was done in 2008 with BMS, angiogram revealed LED 90% ISR in proximal segment. RCA CTO is well collateralized. Syntax score is 15. Today's plan is OCT guided stenting of LED ISR.
Calcified custodian and the wiring we have 2%. Wiring several. Where to go?
Okay.
No. Okay. All right. So we're going to put a 6-inch EBU 3.5 guide with a telescoped catheter technique. Okay. Yeah, we'll bring it all the way to the subclavian. There's some tortuosity there. We'll bring the JR4 there, and then we'll try to make it go down.
Undoswaslo.
That's very interesting.
Okay.
Anatomy.
EBU lesion.
EBU ले जाओ.
EBU lesion. Bit of a tortuosity. Undo श्वास ले दो.
चलो ना कोई पूछो. Contrast injector. Contrast injector.
Contrast injector. Let's bring it back.
The metal wire.
Sam, while you do that, it's pretty interesting case. 17 years ago, it was a bare metal stent in the LAD.
Yeah, it looks like a complex lesion, especially in the caudal view.
Okay. Take shot.
Yes.
Okay.
Okay. So it's just going out a branch.
This should go.
Up there. Okay. Yep. Picture is worth a million.
I think the picture is just a memory. You just follow the picture, right?
Right, exactly. And you have to form the ABU. This window I have in, form it. Good. Okay. And then now let's see if we can sit in. Go to the LV and come back probably. Perfect.
That's it. Let's
see right there. Okay, good sit. Pressure down.
Yes, fine.
Right. The pressure tracing is good. Okay, I'll make it a little steeper and little warm out. Okay, good. Right. Do we want to work in the caudal? Okay. If you caudal, yes. We take a couple of shots. Redo. Ready?
Yes.
Okay. Really flows down to cranium.
Sam,
yeah.
That is collateral to the RCA CTO.
Yes.
Are you going to do it?
No. Leave it for you, Doc.
Okay, sit in.
Right. Yeah. Sit in. Right, right?
Very complex. Yes.
Very complicated case. Let's go caudal again. We'll try to wire in caudal, right?
Yes. Yes.
Run through with it.
So the flow to LAD is not that strong, right?
No, it's down. So most of the right collaterals are coming from the circ in the AV groove, as you can see. Right? So that might work in our favor actually a little bit.
Sam, if you were to guess, I know you're going to do imaging, but if you were to guess the mechanism of restenosis here, do you think this is going to be calcified?
I think it's going to be a neoatheroma, and so yes, it has a pretty high likelihood of being calcified. It certainly would not be neointimal hyperplasia this far out.
So
Do you agree?
So you would be the same as a native atherosclerosis. Then?
Yes, with an added limitation of the stent restricting your adventitia, or the media. So it's actually a little more difficult than the average stenosis like this in a de novo vessel.
I guess the only unusual thing is the presentation was a non-STEMI and not stable angina. So
Right. Okay, let's go cranium.
So new intimal rupture plaque. This does look like a little bit hot lesion, hazy in appearance. Rather be more of a soft plaque than calcified.
Yeah, but whatever is available on the angiogram, both from the right side and from the left side, there's significant calcium in the left main outside the stent.
Okay.
So I wouldn't be surprised if there was a good deal of calcium inside the
So
stent
we're going to
as well.
start with OCT so that we can get an idea of what we're dealing with without any doubt.
So Sam, do you think the catheter of the OCT will be occlusive and you won't have contrast?
Yes, we're worried about that with the EF being 35% and the right being a CTO, etc. But I'm reassured a little bit to see that the collaterals are predominantly coming from the circ.
No, but the question is, when you put the OCT catheter into the
LED,
lesion,
it will be occlusive, but the circ will keep the right alive, hopefully, and the circ will be having flow. So it might be better tolerated than if the right collateral is coming from the
but
from the
doing
LED.
the OCT, I
Yeah.
think that there's a special technique you're going to show us.
Yes.
How we
So
do
let me
that.
just go a little further, right? Anything else? Okay.
No,
Engage.
Can actually
Guide.
inject into the
Right.
So Sanjay,
central
can you tell
lumen.
us what you're doing?
Put occlusive.
So
Ready?
you
I
check it first.
think
Ready?
OCT image will not come optimal.
No, you can actually inject into the side arm and then inject into the main.
Guide.
That way you'll
Oh,
clear,
yes.
you'll get
LED
clearance.
Should we dilate first a little? Right?
Okay.
Right? Pehla thoda dilate kar diye.
One other technique sometimes, Sam, is that if you bring your OCT catheter proximal, inject, then quickly push it down, you might
Yes.
plug a column of contrast.
That's true. Yeah. Although I think we just probably pre-dilate initially and then make enough lumen to have
2
flow around.
millimeter per Rory.
200. Okay. 200.
So if it's occlusive, you could actually inject into the flush port the contrast and then follow it up with an injection into the guide.
Yes.
So that's one way to get a good image, even distal, because it's in any case occlusive. So you will get clearance that way.
Yeah. Yeah, we're going to go with the old school and just dilate first. There's no penalty to dilate here anyway. We're probably not going to dissect anything with a 2O balloon. Even if we want to do atherectomy afterwards, be okay.
Sounds great.
So before you
Yeah, I have to.
I guess the question, Sam, is what is going to be your finding on OCT that's going to make you want to do atherectomy?
I think if it's circumferential calcium, we have more options. It all depends on what tracks in there. I was reassured that OCT catheter went there, so I think odds of needing atherectomy just went down. But my guess is there will be some calcium, but not as bad as we would need to do a rotoblader or orbital.
As long as the balloon is there, maybe a good idea to do a stent boost just while it's there, so you get some more idea.
Yeah. Let me fix the distal wire. It's okay, good enough. One minute. Okay. Make sure it's okay. All right.
I don't know if you can hear, but
Well,
one
sorry,
way
what
to
did you
make
say?
out, I said a good way to make out or get some more information is leave the balloon there in the stented segment and do a stent boost. Sometimes with so much of tissue, you can't see what's happened to the stent even with the OCT. And the stent enhancement technique gives you a good idea before you start.
True, good point. Yeah. Just stopping this thing. unraveling, but you can't do partial. But it's good.
No partial was there. No.
Let me bring it back a little. Too far down, just somewhere split the difference, right?
Okay.
Around there.
Okay.
And the guide is good. Ready?
Yes.
Okay.
That's good.
Are we ready with OCT?
Yes.
Go.
Calibrating.
Huh?
First.
Now yeah.
So there is no movement.
Yeah.
We have to repeat
again.
it.
Yeah, we have to do it
It
again.
was very delayed movement
Yep.
of
Yep.
tape.
Yeah, pressure is good. Let's see the pressure. Pressure is still good. Okay.
Cancel this.
Yeah, this turn.
Okay, it was very delayed movement.
Yeah, it didn't trigger for a while. So we'll do it again.
So are you doing a manual trigger or an automatic trigger?
Automatic.
Ready?
Ready? Okay.
Okay.
Yeah. Try one more. Yes.
Good. Good.
Fine.
Good. Okay, now this will be a good injection. Okay, pressure is decent so far. 1 piece.
You can see it's still occlusive, even though you dilate it.
Yes.
But
The flow is still not normal.
but once you, I think automatic more difficult
Let me
to
pull
apply.
the OCT catheter.
If a manual check is better.
He doesn't like anything sitting in there. Pressure is already sinking a little. Okay, so let's Doug, if you can give your opinion on OCT and let's have some discussion with the panel about it.
So someone, let me see this
that's the
OCT, put it back. This one? Okay, good. So let's see who's right, who's wrong. So we can see the lumen here. So the stent actually, expansion is good. The stent is not under expand, right? Just by looking at that, looks okay here. And the one inside, you will see is it's not too much calcium.
No, it doesn't look like there is any sign of heavy calcium. What does the panel think? Rajiv, what's your interpretation on that end?
Yeah, I'm looking here for Dr. Akasaka, of course. I can't see him here. But to me, it didn't look like calcific nodules. It looks like this should be something that will dilate and restent. But clearly, the mechanism is all neointimal thickening.
I think more like a proliferation, right?
It looks soft, right?
It does look
It looks
soft,
more
neointimal.
fibrotic, yes, rather than calcified.
Can we just play the whole thing from beginning to end once?
What is the size of the vessel?
This is the size.
What's the reference lumen and reference vessel diameter? In the distal healthy part where there is not much narrowing, what is the reference diameter there?
Right, it's a free, right?
Three there.
It's a free O vessel in the distal.
Right, and here is also
It's a
free.
free O. Yeah.
Okay.
So
Since
it's
it's inside
a-
stent, we should probably start with the 3O, right? 3O15 and C.
Okay. I mean, reasonable. But the question is, I'm sure you in your mind, what is the technology? What you're going to do with this kind of ISR?
I think this is, I would still consider this neoatheroma and it's just non-calcified neoatheromatous disease. Any comments from the panel at the auditorium?
So, Tak, I know if this OCT image was not there, you probably would have pulled out laser. Is that correct?
Yeah, if you had not done the OCT, we would have done a lot of preemptive aggression.
But the question is, I mean, how we can prevent restenosis nowadays?
Well, luckily this is a bare metal stent, so a drug-eluting stent will give better mileage already. Okay, especially when it looks like more like intimal hyperplasia type soft tissue. So I think.
So you can see some calcium here from 3 o'clock in between.
My guess would be that DES will be more successful.
Not a lot. It's more like a very soft area.
Is there a utility of a scoring balloon or cutting balloon here with so much of neointimal proliferation?
We were discussing that Kintu just now, and we thought either way would have been fine, but we decided to
Absolutely.
go with a NC to see what's up there.
Would you consider DCB in this case, Sam?
Actually, I have no experience. I have done 3 DCB cases with the peripheral DCB, and they were all for recurrent ISR or with DES.
I see.
How about you guys? Have you used DCB or DEB for these reasons?
Can we see the can we see the fluoro screen, Sam?
Sure, European and the Asia have a lot of good experience in DCB. For us, the DCB just approved a couple months ago in the United States, and the price is so expensive. I just talked to Raji. It's impossible for us to do DCB for a lot of cases. So in my hospital, we get restriction. What patient we should use a DCB? We didn't get approval from the CEO. Only patient with a 2 layer of a stent, ISR, then we're allowed to do the DCB.
Yeah,
how about you, Sammy?
The cost is prohibitive. So
It's a $6,000 US dollar for
our
one
institution is on paper has approved it, but hasn't gotten it for 6 months.
Yeah, we also do very sparingly use.
What's the panel said? I'm sorry.
So talked for same thing for us. Very sparingly used for the DES failure only and 2 layer of stent. But of course, once it is in the hands of the operators, it does get used a little bit more. But this is the bare metal stent failure, so DES would be the first choice, right, Rajiv?
Yeah, I think either way, DES or DCB, I think is good in this case. If you do the laser, do we have a better result? Just do the NC balloon and then the stent or DCB, most likely very similar result. So laser probably is not a lot of people doing that now for ISR.
What are they? I'm sorry, if you can say it again.
I think the laser probably not a lot of people do.
No, laser. I mean, I don't know how you guys feel, but I think the role of laser in coronary was a thing of the past. Before stents came out, I trained on laser. My mentor was a big laser operator, and I haven't used it since 1997.
Yeah. I used cases for unexpanded stent before.
Yeah.
But now when we are sharp, we're coming out. So
exactly.
The role for lasers
It was
almost zero.
Niche application with stent regret with low contrast. Uncontrolled intra-stent explosions.
Samir sir, if you look at the
Well expanded. So we're going to go with the 33 Zions as per the OCT.
are you going to nail the ostium, sir? Samir sir, the areocaudal view shows
the proximal size is about 4.
ostial plaque.
4, I think.
So Samir, there's a question from one of the panelists. You are seeing a lesion at the ostial LAD. What's your plan to do about that? I don't know if you noticed that on the OCT.
So we looked at the OCT when it was being done carefully with as far as the ostial. Yes, that's good. Okay, so let's go up there, right? Yeah, we can deploy there. But if you look at the OCT and the ostium, we have a very good look at it. Can you please show that LAD ostium?
Yeah, can you see that, right? Can you see the OCT? Right. You see OCT? So
let's bring OCT on the screen.
This is an ostium LAD. There's some lesion, but not a lot. But the area is 6.58. So I think very recent to leave alone, right, Sam? You don't want to cover that.
And it looks pretty presentable already. Come out. Were you guys able to see the OCT again? Right now?
bits and pieces. We saw the ostium that we'd asked for, right? We were trying to look at the morphology. We saw it in bits and pieces. It was nice.
Yeah, but what's your opinion after seeing the OCT as far as the ostium goes? Leave it alone or fix it, cover it?
So area-wise, there's no problem at all. It's fantastic. So I don't think it needs to be touched.
That's
I
what I
think
thought,
6.5 is very good. But we would choose our landing zones. This is the area where you see a little bit of calcium there, eccentric. But the proximal landing zone we would have chosen after looking at it carefully. We weren't able to see it very well. So now we see it. Yes.
You
Yes.
see it. I think a little bit is.
There's some disease there for sure, but it's certainly not fix worthy in my opinion. I was actually in the opposite mindset when we started. I wanted to fix the ostium, but the OCT changed my mind.
Is drug-eluting balloon available in India? You guys have experience with that?
Extensive experience.
So then you would prepare this lesion much better, right? You will do cutting balloon and scoring balloon before.
Ready with the OCT,
So-
guys? Let's bring the OCT screen on.
Then with DCB, it is better to go ahead with 1:1. Preparing the lesion by cutting the.
Again, delayed movement. There is some delay. One more. There would be a lot of swirling. Take one more, please. Ready?
Definitely, even before putting a stent, we would have done a great deal more preparation. That is our standard practice.
Hey, hold on. Move back a little bit.
Pull back a little bit. Proceed. Okay. Just 1 second. Okay. Good. Okay. Another breathing. Good. Okay, that should be decent. Yep. It will. So this. Then you again keep it in. Down. Can we? How would I? See the OCT.
The distal part is not that clean. We might need to repeat it actually. The proximal, let's say proximal. The proximal looks okay. So the area is a little bit small here, 4-1. Okay. I think you need to expand
We could
slightly.
post the proximal 1/3 to half of the stent with a what a 375 and at a good high pressure.
Yeah.
Right?
I think so.
14 plus.
I think so.
Right?
I think you
Or we
need
can
to
get a 3.75 and 12 and see. Wow.
5, 6.
So, as a conceptual thing, I'm just asking: is this the done thing that you'd put in the stent and then post dilate it, or you'd prepare it and then put the stent? I'm just asking for our.
I think we are if there was adversity, preparation was our plan actually. Thought about atherectomy, scoring balloon, etc. But the OCT changed our mind. 4 weeks. 4 weeks. So this is a good example of how imaging can save cost. Because without imaging, we would have done too many things preemptively, assuming a lot worse than what it really was. Because of the chronicity of the stent and all those features that we typically go by. How many of you routinely follow in-stent restenosis classification and document it in your cath report and everything? And if you do, which one do you follow? Waxman or anything else?
Sounds like I need an education, Sam. Sorry, I don't do that.
Me neither.
So we do. I mean, a stent failure is actually an opportunity. So it's an opportunity to try and get the best kind of result that the patient can have in the long term. I think any information that we get from imaging, angiogram, stent, enhancement, everything is going to help us. And we would prepare far, far much more than this, and maybe do another OCT run at the end before finally putting the stent. It's just a difference in approach, in philosophy.
Samir, about the classification, I think OCT classification is given by our Japanese friends. The basic classification was
Your son go to UM, right? Which one?
homogeneous, heterogeneous, and
US Tampa. Tampa.
Yeah, I know Ron
Oh,
Oxford
I hope-
also has a.
I hope you don't listen.
homogeneous.
That's good news.
Tak, your mic is on.
Oh, see that? I'm sorry.
Samir, homogeneous, heterogeneous, and layered, these are the three varieties, and they say, even they have done the study that only the homogeneous, the drug-eluting balloon works. Whatever others are malignant. But the new classification, which was published in 2021, again by Japanese colleagues, type 1 to type 6. And type 1, type 2, maximum type 3, it works. Type 4, 5, 6 are again malignant. We will discuss, if we have time, we will discuss during our panel discussion.
So just taking a poll in the audience, if you are looking at the in-stent restenosis, how many of you routinely use intravascular ultrasound or OCT?
Okay, so we have 4 who started the entire stent at a decent pressure, and now we're going to probably repeat the OCT. We'll take one shoot and make sure no perforation type problems are there.
So I didn't see many hands get up. So routine use of imaging is not. Is that because of availability constraint, or is there a financial reimbursement situation?
We use an OCT iris. I think iris is easy for the classification.
Raju, you might know the answer to this. In the US, does the hospital get paid more if you do imaging, or is it still like a DRG or APC bundle?
Yeah, no, sadly, there's no incentive financially. It's a little hit for most cases. Some commercial insurance companies will pay, but most of the time, it's
Ours
not
is a VA,
reimbursed.
so we don't have to worry about that. Luckily, so far, now the administration will probably close down the VA.
I guess philosophically, just we're calling this stent failure, but I would say 17 years of a bare metal stent is a stent success.
Perhaps we should rephrase, rather than stent failure, you use a caged vessel. So you'd like to get the best area that you possibly could, and instead of having a separation of tissue between the 2 layers of stent, have as little in between them, so you get the best stented area.
Sunday.
Okay, that should give a good OCT, hopefully. Now the flow is much improved and he's tolerating everything much better.
I go to New Delhi airport. From Delhi back to New York.
So we expect 34 years of before the next procedure.
So what is our MSA?
I like to come go with
6.92 is MSA, and the percentage of MSA to reference diameter distally and proximally. If you break the stent in half, so if you go by eye lumen criteria, especially in long stents, we divide the stent in two segments and compare the minimum stent area of each segment to its own reference lumen area. And if it's more than 80%, it's certainly acceptable. More than 90% is ideal. Symmetry-wise also, it looks very good. Any comments on OCT stent, post-deployment OCT from the panel or the audience?
I mean, I think it looks really good. I mean, all the numbers looking good. As you said, the symmetry looks good.
Looks very good. I think we're done.
I think we'd love to see an angiogram, Sam.
I'm sorry, what
We'd love to see an angiogram, old-fashioned dye.
If you guys can switch to the fluoroscopy view and give us a final angiogram, that's what Rajiv was requesting.
I'm sorry, what?
If you can give us a final angiogram, yes, now we can see the fluoroscopy. We did not see it earlier.
Yeah, go RF cranial so we can see the proximal LED a little bit better. Cranial. That's good. Yeah. Now it's ready. Spine. Yeah, looks nice.
Beautiful. Yeah, I think everyone in the audience is very happy here. That's a great result. The flow is better in the LAD.
I think it looks nice. Yeah. Any other comments? Any wishes before we leave?
I don't think so, Sam. I think that this went fantastic. Just maybe, and Tejas is here as well, your thoughts on keeping the patient in hospital overnight, or you would send him home this evening?
You know, looking at the design of the society in India, any intervention patient will like to keep overnight for sure.
So, Kintur, would your patient go home, or?
Yeah, they will go home in 4 to 6 hours, depending on the timing of dual antiplatelet agent. And also, at the end of the day, if there are elderly patients, so we end up encountering a lot of elderly patients who are living by themselves. If it's after 2 p.m. or 3 p.m., then we keep them overnight if we finish the procedure after 3 p.m.
That was a great result. Congratulations. That was fantastic.